So here we are, we're at a lecture 11. Lecture 11, lecture 12 is the advanced dry needling of the hip, both lecture 1 and 2. It's going to be split into 2 different lectures. Hopefully we'll see that today's lecture is reduced in length just a little bit. That's always the hope. We'll see if that actually happens. I should have all of our technical issues sorted out. So let's dive right in and see how we do there. Just to my moderator briefly, I don't have my picture up here. Do you have it on yours? That is weird. Okay, so advanced hip number 1, lecture 11. Here we're going to look at, so today's lecture is going to be the upper leg muscles, posterior thigh, hip, adductors, interlateral thigh, the lumbar spine, and the pelvic rotator cuff. You'll note that we've already covered the posterior thigh, interlateral thigh, and the pelvic rotator cuff previously. We're going to cover it again, maybe not as much detail as we have previously. The biggest add-in here is going to be the hip adductors and the muscles in the lumbar spine, iliacus and psoas major. A big piece of what we'll dive into are all of the tendons and ligaments in both the sacropelvic region and around the hip. As you can see off to the right, lecture 12 will be more what we cover in our next lecture 2 weeks from now. There we'll look at all of the regional diagnosis protocols and the perineural protocols. Covered those in a separate lecture, quite honestly, because of the hip. We'll see we do this in the knee as well, is so much of what we see from the physical therapy side. I wanted to make sure that we give plenty of attention there. A little supporting evidence. I looked at just a couple of research articles here. This first from Caballos, and this may have been the one that we've already looked at, but it works, since we're at the hip, worth bringing it back. The objective in this study is a double-blind randomized control trial. This was to determine the short-term effects of dry needling on pain, hip range of motion, and physical function in patients with hip osteoarthritis. In there, they took 30 patients, randomized into 2 groups, a DN group and a sham group. For the DN group, the muscles that they dry needled were the iliopsoas, the rec fem, TFL, and Gluteus Minimus. Actually, I would have changed that up just a little bit, but that wasn't my research study. So the conclusion of the study was that pain, hip range of motion, and physical function was improved after the application of dry needling. And again, they looked at trigger points of the hip muscles in patients with OA. And that came out in 2019. Study from 2017, a little bit older. Here, the authors, excuse me, Hasser looked at a randomized controlled study here, effects of 4 weekly sessions of dry needling on thigh muscle force and range of motion of hip flexion. So they had different groups. Both groups also received a water pressure massage. I feel like they could have left that off to isolate what we were looking at. However, they did include that across the control and across the dry needling group. So the conclusion they came to is that dry needling showed a significant effect on muscular endurance and hip flexion range of motion. And it also showed a significant effect on the maximum force of knee extensors. And this was in 30 elite youth soccer players of a professional soccer club. So just a little supporting evidence for dry needling in and around the hip itself. So we want to go ahead and look now at our 3D kinetic screen. When we looked at the elbow and the wrist previously, we really didn't touch base on it that much. But as we're getting into the lower extremities, it will become a little bit more relevant. So let's go ahead and take a look at the entirety of that 3D kinetic screen. And I'm going to have to reduce here. I meant to open this up and I didn't, so bear with me momentarily. So our 3D kinetic screen, we should have that there. All right, so we'll talk our cervical diagonal rotation. Again, just looking for asymmetries of movement. You're asking your patient, the subject, if there's any pain with these motions. We're doing 5 repetitions. on each side. We'll move into the trunk rotation, just side to side. Again, looking for symmetry of movement from one side or the other. And rotating to her right, she gets a little bit more motion than she does rotating to the left. So if we're looking at a spinal issue, especially thoracic, that might be something that we want to pay a little close attention to. Look at some lumbar linear motion. And here we're just looking again at the quality of movement, the quantity, and if there's any pain or limitation or any substitutions with this movement. Coming down to touch toes, coming all the way up. Our lumbar diagonal rotation, again, we're going to look for any asymmetry in pattern comparing left motion versus right. Also looking to see if there's any compensation that takes place in these motions. Go to the other side. Again, 5 repetitions here. This one, we could consider some of the hip to be involved with this motion. So we do want to pay attention to what's happening here. This definitely would be relevant to things happening both the lumbar spine and in the hips and below. Okay, our figure 4 sitting. Hips definitely play a role here if we lack appropriate range of motion there, and our hip rotators could be problematic there. That's just a pass-fail. Can they bring the hand up or not? Shoulder posterior internal rotation. Not a whole lot to do with the hips there, but I mean, we're going through it. Let's follow through and see how she does here. Again, we're looking for total difference of motion, left versus right, internal versus external with the shoulder. Our single leg stance, we can definitely have a hip issue here. With the single leg stance, we could identify problems with gluteus medius. If there's a difficulty bringing the knee up to horizontal position, that could indicate some weakness in the hip flexor. Sit to stand, definitely indicative of issue with the hips. And looking for compensation strategies that might be going on with this movement that could lead us to some sort of a movement or functional deficit with that activity. Definitely, we'll look at the forward quarter lunge. Again, we're going to go to a diagonal to the left, straight forward, and then to the right. We'll do the rear. Again, back to the quarter, back to the right, straight back, and then back to the left. That will have a little bit of play there. Heel walking, we'll do heel walking and then toe walking. Less to do with the hips here than it is neurologically in the lower extremities, but we will, again, continue progressing through here. We've almost completed our 3D kinetic screen. All right. And so we can take that assessment and look and see, again, are there any asymmetries, left side versus right side? Do we start seeing some compensation strategies as we do more movement? So a nice thing to do would be to conduct the 3D kinetic screen, treat the deficits that you find, and then retest that same movement in that 3D kinetic screen to see if you find an improvement with your motion. All right. So let's move. Let me come back to our PowerPoint. Okay, so let's get into the upper leg muscles here. We'll talk about posterior thigh, semitendinosus, membranosus, bicep femoris. Again, we've already talked about these, but we'll touch base on them again. We'll look closely at the hip adductors. We'll look at the muscles, interlateral thigh, the sartorius, and then all the extensors, the knee extensors, and then lumbar spine, iliacus, and psoas major. In the upper leg muscles, we'll look at semitendinosus, What we will do is move, so I could read this again, your 11th lecture. I'm going to move down into our material where we take a look at complete anatomy. Let's see if I've got that. Let's do a new share here. The adductors. Tell you what, let's bring this in, and I'm going to kill these labels for a second. And then we're going to add our musculature back in. Again, one of the nice things about a good 3D anatomy program is it lets you look at it, sort it, remove layers, add layers. So we're looking at semimembranosus, semitendinosus, and bicep femoris. Let me add in the other head. So basically, our hamstrings, because they do come in and attach at the hip, we have to consider them as relevant to what we're dealing with. Any sort of hip musculature, there's a lot of stuff that comes in around the hip. We have to consider issues. Let me go ahead and hide that. In and around the lumbar spine, we have to consider the abdominal muscles. They attach onto the ilium themselves. And so if there is some dysfunction, they could be playing a role. But specifically here, the hamstrings attaching on the ischial tuberosity. We'll look a little bit closer at this when we get to our tendons and ligaments. But let's look at our needling piece here. I think we'll have that. Back, where did my lecture go? There it is. Okay, so for the treatment piece, again, we're going to take our posterior V-notch. We're going to needle lateral about 1 palm breadth, proximal to the popliteal crease. And let's swap again. Here. So semimembranosus, semitendinosus. We're going to grasp that again, if you can imagine that V-notch, 1 palm breadth proximal to popliteal crease, and needle about 45 degrees away from midline towards the medial aspect. Okay, and we'll skip the slides momentarily, but similar for the bicep femoris, same thing. Instead of going to the medial side of midline, here we're going to go to the lateral aspect of midline. Again, want to stay away from that neurovascular bundle there, right in the midline. All right, let's come back now to, okay, we looked at bicep femoris, the long and the short head, and partly for the reason for bicep femoris, long and short head, for needling it at this location is one, it lets us get, again, the long and the short head of biceps femoris right there. Whereas if we cut it up a little bit higher, we would miss that shorter head of that muscle. We won't always needle the hamstrings in this area, as we'll get a little bit more today. We'll find that there are times we will needle that right off of the ischial tuberosity, or we may take it in mid-belly of the bicep or the hamstrings, either the medial side or the lateral side. Just depends on where we are. But if we're wanting to elicit a change down low, is always a first good place to see if we can get a release of that muscle. So we've already played number 3. Let's move on to the upper leg muscles here, the adductors. Adductor Longus, Brevis, Magnus, Pectineus, and then Gracilis. So I'm going to move down to our 3D anatomy so that we can look at those there. Let me come back. There we go. Okay, let's come back to here. Let me come back to my library for our adductors. So I'll start with, well, we started with our hamstrings. I'm going to go ahead and remove the hamstrings since we have already talked about those. And then we'll bring our others on. So let's hide semitendinosus, semimembranosus, and bicep femoris, short and or long and short head. Okay, so that'll get us over to the adductors. So very first, let's just start more proximally. Pectineus, as you can see, its origin is on the superior pubic ramus. It inserts into the pectineal line of, I'm going to rotate a little bit here. So it comes to almost a posterior orientation, or it does come all the way posterior into the pectineal line of the femur. Because of that orientation there, its action is it adducts and it flexes the thigh at the hip joint. One could be forgiven for arguing that it provides a little external rotation as well. Innervated by the femoral L2-3 and the obturator nerve L2-3. So let me go ahead and just fade that. We'll come a little bit deep to the adductor brevis. Actually, I'm going to hide Pectineus. So the adductor brevis, its origin, the body of the pubis and the inferior pubic ramus. So boy, it's hard to see with that in place. As we look on the posterior side, it really sits posterior to adductor longus, as you see. It's not highlighted yet, but as you see there, it sits posterior to that behind anterior the pubis. It inserts in the proximal 1/3 of the medial lip of the linea aspera. So if we take another posterior, they're really making me work for that. It's overlaid with Adductor Magnus here. It's a little harder to see, but again, it sits almost on a posterior aspect, and so its action adducting the thigh at the hip joint. Again, one could almost be forgiven for considering that it also has an external rotation motion to it. It's innervated anterior branch of the obturator nerve. So let me hide that. Let's take a look now at Adductor Longus. I'm going to come out so that we can see that a little better. So Adductor Longus. Here, the origin anterior surface of the body of the pubis, and it inserts into the middle 1/3 of the linea aspera of the femur. Again, you can look and see it takes a little bit of a lateral or a posterior approach there. Its action again would be adducting the thigh. I would also recommend possibly a little external rotation. It innervated by the anterior branch of the obturator nerve as well. So we'll hide that, and then we'll get to let's get Gracilis first. So Gracilis being one of the 3 muscles that make up the pes and serine distally. You'll see that it's the medial most tendon of this adductor tendon group that we see here. Its origin, body of the pubis, inferior pubic ramus. It inserts the medial aspect, the proximal part of the tibia, further distally. And its action is flexes and immediately rotates the leg at the knee joint, and it assists in adduction of the thigh at the hip joint. It also innervated by the obturator nerve. So lastly, we'll get to the Adductor Magnus. All right. So its origin being, or its first origin being posterior to the origin of Gracilis. It's the inferior pubic ramus and the ramus of ischium. So we see it also as an origin further down, almost to the ischial tuberosity where the hamstrings attach. So interesting correlation there. Its insertion is at the gluteal tuberosity, the linea aspera, the medial supracondylar line, and the adductor tubercle. So Adductor Magnus has a really large footprint. It is a rather flat strap-like or a flat muscle, but it can be needled in a couple of locations. We will predominantly needle it up high, but for, say, later in the knee, we'll talk about our genicular protocol. We'll needle directly into the tendon further distally there. So that is the adductor group. Let me get my program together here. Okay, so let's come back here. So for treatment, we're going to break the hip adductors into two different groups. The first will be the Adductor Longus and Magnus and the Gracilis. And then the second group will look at the Adductor Brevis and then Pectineus. For the Adductor Longus, all right, so for Adductor Longus, Magnus, and Gracilis, did I leave? I did. So what we're going to do is we're going to go in the sideline. That's going to do that on it again. Bear with me. This may try to roll on me. So we're gonna go sideline with the treatment leg is mat side. It's about 60 degrees of hip flexion, and the upper leg is straight and supported on a pillow. We're going to identify 4 finger breadths distal from the symphysis pubis with the middle 3 fingers splayed apart. We're going to have the subject attempt to adduct into your hand. The most prominent muscle being the gracilis. So here, needle placement will be at 4 finger breadth distance from the symphysis pubis. The first needle will be at the middle finger into gracilis. The second needle is going to be 2 finger breadths anterior into adductor longus. And the third needle will be 2 finger breadths posterior into adductor magnus. Needle length is going to be about 4 centimeters, and it's going to go from the medial to lateral angulation. In this instance, we're going to go straight down to the mat. Alternate treatment position, patients in supine, legs abducted onto the clinician's thigh, which is resting on the treatment table. And that's the approach that we used in our introductory lab. Here, let's just get a little bit more depth and a little bit better approach to that. All right, so let's move to. All right. So we're going to come down. You see, we've got the treatment leg mat side. We're going to come down about 4 finger breadths, and we're going to have them attempt to adduct into those fingers. So first needle will go again straight to the mat. We're going to go 2 finger breadths anterior to that. And then we'll come back and we'll go 2 finger breadths posterior to that. Really nice treatment approach to catch the bulk of the hip adductors. Again, if for some reason you have a difficult time getting your patient in this position, you can always go into that supine position and then do the thread through the bulk of those materials. But here, let's just get a direct approach into those muscles. All right. So now let's look at Pectineus and Adductor Brevis. So we just talked about their location. For these, there'll be 2 distinct separate needlings. The first one here, we're gonna be supine. Come back. Lower extremity is going to be abducted on a bolster or resting against the clinician thigh on the table. Needle length is about 4 centimeters, and there's no backdrop here. What we're going to do is we're going to palpate the inguinal region to locate the femoral artery distal to the inguinal ligament. We're going to go from lateral to medial. It's located at the femoral nerve, artery, and vein. Pectineus also forms the floor of the femoral triangle, and caution here to be medial of the femoral neurovascular structure. So once you find and palpate the femoral artery, we're going to be medial to that. So also, if you cannot palpate the femoral artery, you must not needle this region. You've got to be able to identify that in order to do this in a safe manner. So we're going to palpate both the femoral artery and the uppermost aspect of the symphysis pubis. And for the pectineus, the needle location will be at the midpoint between those two landmarks. And then doesn't say it there. It's going to be 1 finger breadth distal and an anterior to posterior angulation with a 3 to 4 centimeter needle. For the adductor brevis, we're going to move from the symphysis pubis. We're going to move laterally 1 finger breadth and then distally 2 finger breadths for needle location for there. That's going to be a little bit deeper. We're going to use a 4 to 5 centimeter needle for adductor brevis.
Yeah, once I drop in, then get that lower.
So we'll do pectineus first. I'm going to palpate femoral artery. We're going to move midway between there and symphysis pubis, 1 finger breadth inferior, and needle anterior to posterior for pectineus. For adductor brevis. For pectineus,
We're going. All right.
and we'll find our landmarks. We're definitely locate that femoral artery. We're going to be 1 finger breadth lateral from symphysis pubis and 2 finger breadths inferior for pectineus directly into pelvic femoral triangle as the floor. Okay, now we'll move on to the upper leg muscles, the interlateral thigh, sartorius, rect fem, and then the vastus lateralis, intermedius, and medialis. I'm going to move through these sartorius. Let's get on sartorius. Rect fem, let's get down to our 3D anatomy on these. Let's see, here we go. Bring that in. Okay, so for sartorius first. Sartorius itself, its origin is, get nice and tight here. The ASIS, anterior superior iliac spine, we'll move that. We'll look at momentarily the Sartorius tendon. It's a very short structure, but with a strain there can be clinically relevant. It inserts medial aspect of the proximal part of the tibia, another piece of the pes anserine, along with Gracilis, and then 1 additional. Its action, it flexes, immediately rotates the leg at the knee joint, and it assists in flexion, abduction, and lateral rotation of the thigh at the hip joint, innervated by femoral nerve segments from L2 and L3. So longest muscle in the body, very circuitous route to get from its origin finally to its insertion. We'll hide that. And again, we've already looked at the muscles of the thigh. Rect fem from the anterior inferior iliac spine, supraacetabular groove of the ilium, search into the tibial tuberosity via the patellar ligament. And it extends the leg at the knee joint. And because it crosses that hip joint, it flexes the thigh at the hip joint, and it's through the femoral nerve. Vastus lateralis. Zoom out just a little bit. Its origin is the intertrochanteric line, greater trochanter, the gluteal tuberosity and lateral lip of the linea aspera. So we have to turn a good bit to see its footprint. It inserts in the tibial tuberosity again via the quadricep femoris muscle and the patellar ligament there at the lateral border of the patella. We look at the vastus medialis. Its origin is the medial part of the intertrochanteric line. Let me get rid of rect fem real quick. And actually, let me go ahead and get rid of Vastus Intermedius so that we can see Have a little better look at rec fem. Again, its origin, anterior lateral surface of the body of the femur. It inserts tibial tuberosity via the tendon of the quadriceps. Its action is extending the leg at the knee joint. Again, femoral nerve L2, 3, and 4. Lastly, but not leastly, we'll look at vastus intermedius. Its origin, anterior and lateral surface of the body of the femur, and inserts again via the patellar or the quadricep tendon into the tibial tuberosity. So for treatment, Sartorius can be treated several ways. The best and ideal way to treat, let me come back, Sartorius is 2 to 3 finger breadths distal to the ASIS. We can have our patients lift the heel towards the buttocks, and we can identify Sartorius, and needling at that location is ideal. It can be and will be when we get to the knee, needled further distally into the pes anserine itself. But this is a really nice treatment location right here. Let's come to number 6, take a look at that. Okay, so we're going to palpate the ASIS, and then we're going to drop. We're going to palpate, make sure we've got it, and come down 2 to 3 finger breadths just into that musculotendinous junction for Sartorius. Come down. Here we'll look at rec fem. We'll walk through these: vastus lateralis, intermedius, and medialis. And we'll come and see these. So, rec fem, we're going to locate superiormost aspect of the greater trochanter and the iliac ASIS. We're going to find the line where that bisects and drop needle directly there into the myotendinous junction for rec fem. No worries, we will needle rec fem a little bit more directly in a moment as we do vastus intermedius. But for vastus lateralis, we're going to find a midpoint between the knee joint line and greater troch, and just anterior to the iliotibial band, we'll needle into the bulk of the medial muscle of vastus lateralis. And apparently we're going to do it. Oh, so that was a direct approach. We can also do a threading approach. Same location. We're just going to go from anterior to posterior to thread through that musculature. Okay, so since we're on the videos, we'll move into vastus intermedius. For vastus intermedius, we will find apex of the patella, find the ASIS. We're going to find midpoint, and then we're going to needle anterior to posterior direction down to the femur as our backdrop to get vastus intermedius. We will needle through rectus femoris as we're heading towards our backdrop to needle vastus intermedius. Okay, let's come back. Okay, so let's move on to our lumbar spine. Here, we want to look at iliacus and psoas major. We dealt with these a little bit more earlier, or psoas we did when we were dealing with the lumbar spine. We'll look at a couple of different ways that we can needle these. First, iliacus. We'll look at that momentarily, as well as psoas in our 3D anatomy. So let's jump straight to that. While that pops up. Drink water. All right. So for ilio-psoas, let's start with psoas first. Definitely they work as a unit on the hip. But let's come from a posterior view to look at origin of psoas, origin transverse processes of L1 through L5, and the vertebral bodies of T12 to L5. So we can see on the vertebral bodies, T12 and L5, and then the transverse L5 down to L1 down to L5. Also has attachment onto the disc. The discs are not represented, but they would be connected there. Insertion, the lesser trochanter of the femur. Let me get all the way down here. And so we see its location right there. You can see that we reference the psoas major as the iliopsoas, quite honestly, because they merge together, form a common muscle, and then myotendinous attachment or tenoosseous attachment onto the lesser trochanter. Action, it flexes the thigh at the hip joint and it flexes the trunk. That's psoas. Innervated by the anterior rami of the first, second, and third lumbar nerves. So let's swap here. I'm going to go ahead and fade psoas so that we can look at iliacus. Its origin, the iliac crest. The superior 2/3 of the iliac fossa, so upper part of that iliac fossa right there. And then the anterior sacroiliac ligaments, which would be sitting, well, they're going to be deep, and they're not represented here, but beneath psoas, those ligaments would be sitting right there, and it shares an attachment there. Its insertion is the lesser trochanter of the femur via the tendon of the psoas major. So there we see how it has that common insertion with psoas. Here, psoas is actually innervated differently by the femoral nerve L2 and L3. So let's come back to, all right. So here we're going to look at the dry needling of the iliacus and psoas major. So iliacus, we'll look at this in a couple of different ways. Here for iliacus, we'll do this either in supine or sideline. Here we're going to do this first in the sideline position. Needle length will be a minimum of 3 up to 5 centimeters. Backdrop is none or the internal ilium. Precautions here, definitely the lateral femoral cutaneous nerve, the deep circumflex iliac artery, and the vein ilioinguinal nerve in the anterior branch of the iliohypogastric nerve. Here, the patient's going to lay in sideline. The pillow is going to be placed between the iliac crest and the rib cage on the downside, and have the upside arm held in full abduction over the head. The whole reason for that is to open up that space between the superior aspect of the iliac crest and that lower rib. We're going to palpate for the superior aspect of the iliac crest at the sideline apex of the iliac crest. We're going to use a splayed finger technique and push the skin and underlying abdominal oblique musculature medially to hook over the iliac crest. Here, the needle angulation is going to be from 1 finger breadth medial to the iliac crest, and it will be cranial to caudal with a slight lateral angulation directed toward the internal ilium as a backdrop. Absolute caution here to avoid the medial angulation of the abdominal contents. So if you're unable to get in this sideline position and be able to move medially or closer to the table from the iliac crest, then you're not going to be able to get the proper angulation back towards the ilium. So if you cannot do that, then you cannot do this needle. It can be very effective because you can get that needle anywhere along this area as long as your patient's body morphology is such that it allows to get in there. Obviously, a much larger person with a lot more adipose tissue, a lot more challenging to get into that. So you have to look at your patient to be able to do that. Oh, let's skip the vastus medialis. So a couple finger breadths for VMO, cranial and medial, and we're going to needle about 45 degrees towards femur as a backdrop. Now, iliacus. So in this sideline position, you can see the towel underneath. Let's open up this space. We want to be able to push those contents over the iliac crest medially so that we can place the needle and advance it laterally towards the iliac crest. Absolutely, if you have to needle, if your needle angulation is not either parallel or away from the table, if your needle angle is toward the table, then you can't do this needle into iliacus. No worries there. There's a different way to do it that we'll do next. Or we'll look at psoas major next. So here we'll look at psoas major and iliacus. In this situation, let's say we weren't able to take, let me come back. We weren't able to get to this lateral approach, this sideline approach. No worries. Let's go in the supine position. Here for psoas major and iliacus, two different needling that we'll do. Needle length here is going to be at least 3 to 5 centimeters. Backdrop is either going to be none or down to the ilium. So for psoas, you may or may not hit a backdrop. For ilium, you may or may not, but if you do, it needs to be laterally projected into the ilium. So first procedure, we're going to palpate for the femoral artery, distal to the inguinal ligament. We're going to go 2 finger breadths lateral to the femoral artery. And for needle placement, it's going to be anterior to posterior, just sky side down to the table toward the ilium for the psoas major. For the iliacus, we're going to palpate for the ASIS. So similar to what we did for Sartorius. Palpate for ASIS. And in a line connecting the, both ASIS, we're going to move 2 finger breadths medially for needle insertion with a posterior and slightly lateral angulation toward the ilium for iliacus. So first thing, palpate femoral artery. Next thing, once we find that, we're going to move 2 finger breadths laterally, and we're going to needle anterior to posterior down to the table for treating psoas major. For iliacus, we're going to find the ASIS. We're going to draw a connecting line from one ASIS to the other, and then we're going to move medially, and we're going to needle slightly lateral to the iliacus, to the ilium as our backdrop for iliacus. Definitely a great way to treat that. If you can get it in sideline, get a little bit more threading possibly through that, but anytime we're dealing with iliacus, so as the iliocostalis, this anterior approach, supine approach, very good. You can get both muscle at one time. Okay. For QL, Quadratus Lumborum, we will look. Do I talk about that? Okay, so since we're here, QL origin, the posterior border of the iliac crest. So right here, it inserts into the inferior border of the 12th rib, and then L1, 2, 3, and 4. It's innervated by 12th thoracic, 1st to the 4th ventral rami of the lumbar nerves, and alone it laterally flexes the vertebral column together to cause the depression of the thoracic rib cage. One thing of note, and we'll see this in a moment. Well, actually, let's get to this next slide. What we'll do is palpate for this lateral. You see this here in green, the lateral border. There we go. A lateral border of Iliocostalis. Lateral border of Iliocostalis creates the medial border of Quadratus Lumborum. We're going to follow its path distally to the iliac crest, and then 2 finger breadths lateral along the iliac crest and 2 finger breadths superior will identify our needle insertion point. So we use that lumbrical grip to locate, or the profundus grip rather, find the lateral border of Iliocostalis. 2 finger breadths along the iliac crest, laterally, 2 finger breadths superiorly will be our needle placement. Here, angulation is going to be anterior to posteriorly, and you'll needle through QL here before you hit psoas major. So I'll lump these two together in a posterior aspect. If we want to get this upper piece, we absolutely can get psoas major back here, but this is also the same way we will get QL. Here. All right. And so here is QL in psoas major. You can see I'm up just a little bit here. I'm using that profundus grip to locate that lateral border of Iliocostalis. When I locate that, I'm going to move just a couple finger breadths lateral and then superior for QL and Psoas major, and posterior to anterior. Okay, we move on to the pelvic rotator cuff. Biggest thing that we're going to add here, we'll cover briefly, is the coccygeus and levator ani. We've covered the gluteals, TFL, piriformis, and the deep rotators. But let's do, I'm going to slide all the way down to coccygeus. Coccygeus, the origin, the sacrospinous ligament and the ischial spine. So here, and then it inserts into the lateral margin of the coccyx and the related border of the sacrum. It's innervated by the pudendal nerve and the sacral nerves S4, S5, or S3, S4. Its action is it pulls the coccyx forward after defecation, closing in the back part of the outlet of the pelvis. So we do tend to see when we're dealing with hip issues, they can get very confused, both from a subjective standpoint from a patient, and then from an assessment standpoint of where this pain is actually located. And so coccygeus, definitely one that we can needle. We'll cover that in just a moment. We'll cover it in a lot more detail when we get to lecture 16 over the pelvic floor. For the levator ani, or the iliococcygeus, so it's represented in this gold and yellow color. Right above you see the coccygeus, and so that's more, the coccygeus more at the junction of the coccyx and the sacrum. Iliococcygeus is a little bit further distally enveloping the coccyx as a whole. Its origin, inner surface of the side of the lesser pelvis, and it inserts in the inner surface of the coccyx, the levator ani of the opposite side, and the structures that penetrate it. Its action also supporting the viscera in the pelvic cavity. So this forms a large piece of the pelvic floor. And so it likewise can be needled very superficially right off of the coccyx. So let's look at our treatment. So I'm going to advance through a little bit. So glute max, we locate superior aspect of the greater trochanter, which we've done here. We'll find the PSIS. Then a connecting line midpoint, we will needle posterior to anterior into glute max. Okay. Glute med. For the glute. Now let me come back. So for glute med, it's just going to play. So let's come all the way. Let's get down to it. So for glute med, we're going to follow the iliotibial band or tract as it's moving up to attach onto the ilium. We're going to carry 2 to 3 finger breadths medially and 2 to 3 finger breadths distally to isolate gluteus medius. Again, posterior to anterior with the ilium as a backdrop. For gluteus minimus, I'm going to come all the way to gluteus minimus. So for gluteus minimus, we'll locate, pause if it will, the iliac crest, cranially, and the greater trochanter inferiorly or caudally at a midpoint, and this is at the level of the iliotibial band, the IT band. At the midpoint there, we're going to needle from a lateral to medial trajectory, landing onto the ilium as our backdrop, right at a midpoint. This is also going to be the needle location for TFL, or very close to it. There we are with glute min. For TFL, we'll have 2 locations or 2 approaches. Either a direct, very similar to what we just did with glute min, or we can take a threading approach from the superior aspect of thread through that muscle in the same location. So we'll take lumbrical grip, grasp TFL, needle posterior to anterior through that tissue. Okay. Piriformis.
For the piriformis, the
The
patient.
piriformis. I'm going to skip the chit chat here. What we're going to do is locate the cranial-most aspect of the greater trochanter. We're going to move 2 finger breadths in a frontal plane towards the medial aspect, and then 1 finger breadth cranially, and then we'll needle posterior to anterior to land into the lateral most portion of piriformis. When we looked at the pelvic rotator cuff, we'll look at this more when we get into the pelvic floor because it'll be more relevant when we get to that. Piriformis can actually also be, let me come back. We can also needle it off of the sacrum right here, but we'll cover that more detail in the pelvic floor lecture number 16. So for the deep rotators, come all the way down here. It's just going to roll on me. So here,
Inferior gemellus, the
I think we
obturator
can hear me
internus,
talking
inferior
here.
gemellus, obturator
What we're going to
internus.
do is, so we're going to find the greater trochanter again. And everything centers around that greater troch. Nice, easily identifiable landmark. We're going to come in 2 finger breadths from that, and we're going to drop 1 to 2 finger breadths, and we'll needle posterior to anterior. We're looking at the neck of the femur is our backdrop. And we're going to go a redirection method. So straight down, then we'll go superior, then we're going to redirect inferiorly for our third approach to land in Quadratus Femoris. So again, these muscles are much too small to identify individually. And so we take almost a pecking approach to make sure that we catch all of those. In this example, I needled redirected twice after initial needle insertion. It can be done more than that. I'd caution not to overly stimulate. So we get to Coccygeus. And let's look here. So again, for Coccygeus, so I've got a little model that I've used here.
Knee length here will be 2 up to 3 centimeters, and there will be no
So I've
backdrop.
got some audio, but
Precautions here for the
it's not very
sacral
loud.
nerve.
So for Coccygeus, what we're going to do, I'm going to bring right out to here. So Coccygeus is at the junction of the sacrum and the coccyx. So what we want to do is we're going to drop our needle. We're going to identify this lateral border of the sacrum. We're going to drop our needle right onto that. Once we've determined what our depth is, we're going to retract slightly. And we're going to use our fingers to push that needle 1 finger breadth more laterally. And then we're going to advance our needle 1 finger breadth further than where we were with our test needle onto the sacrum. And it's a superficial muscle, and there's a lot of contents anterior to it. So we're just going to give ourselves 1 centimeter more than we found with our depth on the sacrum.
Then we'll move 1 finger breadth laterally until you feel the drop off of the lateral sacral border, and we'll needle in a.
Just that a little bit. So we'll do our first needle there onto the sacrum. We're going to drop off the lateral aspect, giving us just 1 more centimeter off of that. And as you can tell, I'm going to finish that. New share here. Nope, wrong thing. Okay, so then we'll look at Coccygeus. Same process. We're going to come down. We're going to needle onto the coccyx itself. We're going to then move 1 finger breadth lateral and give ourselves 1 to 1.5 more centimeters into the levator ani or the Iliococcygeus. Again, we'll palpate. And when do you need to needle this? If you have a patient that has some pelvic floor issues that are confused with hip or lumbar for that matter, very frequently a person with this sort of a problem complains of back pain, when in fact it is more of a pelvic floor issue. This would be a good indication that it would be time to try to needle that. But again, we're going to needle down onto the coccyx. Obviously, this requires a lot of pre-treatment discussion with your patient about what you're going to do, why you're going to do it. Here we've come in, we've dropped our test needle down onto the tailbone, and now we're going to move finger breadth lateral. We're going to give ourselves just 1 to 1.5 centimeters additional to come into the muscle of the levator ani or Iliococcygeus. Okay, now on to the bread and butter here, the tendons and ligaments. As you see the list, there are lots of ligaments involved in the sacropelvic region and in the hip. The sacropelvic region, I'm starting at the linea alba. We covered that in the thoracic piece because it does attach at the pelvis, the pecten pubis. I am including that here. How often do we need to needle linea alba? Probably not that often. I have done it several times clinically. Sometimes it needs to be done. So I want you to have the tools at your disposal to do that. So we'll start here. Okay, so let's move now to our tendons and ligaments. There we go. All right, so let's start with the ligaments of the hip actually first. And let me clear all of what we've got here. Get rid of our labels. Let's just cover these things. So obviously hip, we consider the all of the sacropelvic, sacroiliac tendons and ligaments, or the ligaments, simply because of its location. It can be involved. It's very frequent to have a hip issue and have to deal with an SI problem as well. But we'll start first with, bring this up, the sacrotuberous ligament coming off the ischium onto that border right there. Also sacrotuberous ligament, part of it is not shown, but it also extends up to the PSIS. I'm going to hide that, brings us to the sacrospinous ligament. Coccygeus sits just anterior to that. So anytime we're needling Coccygeus or sacrospinous ligament, we're also needling the others. They have the exact same footprint. On this aspect, we can also talk about the sciatic bursa of Gluteus Maximus. It's a difficult place to needle because the sciatic nerve sits right here. But I have found both clinically and personally that the sciatic bursa of Gluteus Maximus can frequently be inflamed if we spend a lot of time sitting, or if we have some proximal hamstring issues. That sciatic bursa of Gluteus Maximus can frequently be problematic. So needling just onto that bursal tissue can be very helpful clinically. We see the ischiofemoral ligament on the posterior aspect of the hip joint, the iliofemoral ligament, or the Y ligament that we learned about. We move further anterior, we get to the pubofemoral ligament. Of importance, we'll also see the iliopectineal bursa. Let's see, we also have the greater trochanteric bursa, or the trochanteric bursa of the Gluteus Maximus, the trochanteric bursa of Gluteus Medius, and the bursa of Gluteus Minimus. in all reality and all truth, these three are probably continuous with each other, forming a single bursal component. For purposes here, they're definitely shown as three distinct, and we can definitely needle onto the apex for our trochanteric bursitis problems. We do see inguinal ligament. Here we see the symphysis pubis. I'm sorry, the interpubic disc in between that comprises the symphysis pubis. And that's the bulk of the ligaments that we're going to look at here. Let me move back to, I don't need a poll. It's where we're looking at here. So just quickly on the review, we talked about linea alba and the thoracic spine. If a person is dealing with diastasis recti, definitely want to be cautious of what's going on here. It's less than 1 centimeter for penetration. But for that, let's go take a look at that. So you'll palpate and you'll find the delineation of the linea alba. And again, this is a 1.5 centimeter needle that I'm using right here. And I'm not using all of that to get into that linea alba. Come back, change the share. We'll look at the adductor tendon. The adductor tendon being just the ligamentous structures that make up all of the that adductor grouping there at in the groin. Adductor longus, adductor brevis, adductor magnus. Pectineus is not included in that, but you can definitely needle through that tissue. We're going to drop 1 finger breadth from, come back. So at the interpubic disc, the pubic symphysis will palpate intermedial adductor tendon as you resist adduction, and then 1 to 2 finger breadths lateral and inferior to determine the needle location. Needle angulation is going to be 45 degrees inferior and lateral with no backdrop. So a 3 centimeter needle is all we're going to need here, threading away from the midline to thread through that group. Let's come to that. So here I'll come in, find that symphysis pubis. I'm going to find that adductor tubercle or that adductor group right off. I'm going to drop, and I'm going to needle approximately 45 degrees into that adductor tendon. Actually, it's all 3 of those tendons. The inguinal ligament, at times, it can be irritated, inflamed because it's in the hip region. We go ahead and want to be able to needle that if necessary. We're going to find it's 1 finger breadth lateral and or medial and inferior or caudal from the ASIS. Again, it'll be 1.5 centimeter. It's going to be very superficial to get to that. So let's jump to number 15. Again, ASIS, we'll move 1 finger breadth inferior, 1 medial, 1.5 centimeters for the inguinal ligament. Interpubic disc, we'll locate that space between the pubic bones. Then we're going to move caudally just 1 finger breadth to identify the needle location. We're just going to be anterior to posterior. Our needle length will be 1.5 centimeters, and there's no backdrop.
For the interpubic disc at the pubic symphysis, the patient will be in the supine position. This will be a shallow needle stick. It'll be 1.5 centimeters, and there is no backdrop.
Okay, again, obviously need to have some discussion with your patient prior to this procedure. So clinically, when do we do this? There are times where you do have patients with inflammation there at that interpubic disc. Absolutely appropriate to needle into that to get a resolution. And usually once, twice is all that you have to do to needle to that. We'll drop one finger breadth down from the cranial most aspect of that disc and needle anterior to posterior. Sartorius tendon is going to be very similar. Previously for Sartorius, we found the ASIS, and then we dropped 3 finger breadths, 2 to 3 finger breadths to get into the muscle itself. For the Sartorius, we're just going to drop 1 finger breadth off of ASIS and needle down to the ASIS, or there may be none, but odds are we'll hit the ASIS or the ilium as we're approaching that. For the rectus femoris tendon, so with our rec fem, our proximal needle location, we needle at a line that bisects the lateral apex of the greater trochanter and the ASIS, and then we needle right here. To target the tendon itself, we're just going to find a midpoint to needle there between ASIS and that proximal rec fem location. So let's do that. Well, that was the Sartorius tendon. And we're just going to drop 1 finger breadth and identify Sartorius, and just inferior to its attachment, needle down to the ASIS, just inferior to it for the Sartorius tendon. For the tendon, right? Yeah, the rec fem tendon, we'll locate that lateral aspect, apex. We'll find the bisecting line between there and the ASIS, and then we'll find a midpoint to needle into the rec fem tendon. For the iliotibial tract, will be the same as our needle approach for a direct approach into the IT to TFL. We'll find cranial most aspect of the greater trochanter, follow the IT band to the iliac crest. We'll find a midpoint and needle from lateral to medial. So subject here is in sideline position. So identifying the greater troch, iliac crest, and we'll needle through that tendon. Sometimes with a backdrop, we're trying to catch Gluteus Minimus at the same time. We may find that we have some backdrop associated with that. So that's iliotibial tract. For the sacrotuberous ligament, here we have 3 different locations. It can be symptomatic at the PSIS, at the sacrococcygeal junction, or at the ischial tuberosity. Here in the little picture, you see the burst of Gluteus Maximus, which can be an issue. But the sacrotuberous ligament here represented by this big, broad ligament itself. Here, needle length 3 to 4 centimeters at the PSIS. Backdrop is down to the lateral sacral border. Precautions there for the medial cluneal nerves. On our sacrococcygeal junction, needle length will be 2 centimeters. There is no backdrop or the sacrospinous ligament right there. And then lastly, at the ischial tuberosity, we're aiming for the medial surface of the ilium. Come back. I'm sorry, medial surface of the ischium, just the medial aspect. Being aware that the lateral to that is where we see the sciatic nerve. So we're going to catch either here or here at the sacrococcygeal junction, or just inferior to the PSIS. So we can needle at or just inferior to PSIS. We'll drop down. Sorry, lost my lid. We also do it at the sacro-coccygeal junction. Again, this is placement. Definitely talk to your patient about what you're doing, why you're doing. Then going to backdrop on the sacrum or the coccyx. And then lastly, down to the ischium, that medial surface of the ischium where the sacrotuberous ligament has its inferior most attachment. Ischial tuberosity frequently involved with tendinous pain dysfunction. Important to know where everything is, comfortable with your three-dimensional anatomy to be able to needle there and do it safely, but still get some really good response for your patient. Okay, then we'll come up more proximally, the tendons of Iliocostalis and Longissimus. So as you can see in the yellow piece, they really come down beneath the thoracolumbar fascia to create a single band of tendon as they're coming down. And so to treat those as a single unit, from the PSIS, we'll go 2 finger breadths medially and 2 finger breadths superiorly, just posterior to anterior, to needle into those. Simultaneously, we probably will definitely also needle into the multifidus and to the iliolumbar ligament on the iliocostalis side. But let's come in and take a look. Number 21. So we'll locate PSIS. We'll move 2 finger breadth superior. And then 2 finger breadths medial. Again, not only hitting those terminating tendons of iliocostalis and longissimus, but also catching iliolumbar ligament and multifidus at the same time. Get a twofer. Okay. The interosseous sacroiliac ligaments, we covered these when we talked about our pelvic rotator cuff, but let's look at them again. These are our SI joint ligaments that give us our issues. Here we'll go from a medial to lateral angulation into those SI ligaments. Here we'll do some unidirectional rotation, get some twisting, mobilize that ligamentous tissue, that soft tissue. We'll come in here. We'll do it based off of the PSIS. And let's look at that at number 22. Get that superior piece, and then we'll drop and get a little bit more inferior, also angled, almost like they're trying to terminate at each other there deep in the sacroiliac joint. Normally, treatment-wise, we can do some unidirectional rotation and manipulate that ligamentous structure, get us nice, good response out of those. Okay, the iliolumbar ligament. We talked previously about coming 2 finger breadths superior to the PSIS. Here, what we'll do is, let's just come to it. We'll palpate for the interspinous space between L4 and L5, and catch back up. going the wrong direction. No, I'm not. Okay, we'll palpate interspinous space between 4 and 5. And for the iliac crest, we're going to draw a line between the interspinous space closer to the inferior border of L4 spinous process, laterally to the iliac crest. And needle placement will be at the intersection of the helper line and the iliac crest, P to A angulation with no backdrop. So if we find inferior aspect of L4, carry it over to the iliac crest, and just superior to that, we can drop that needle into iliolumbar ligament. So I've located spinous process of L4 and the line where it meets with the ilium, and just superior to that, we'll needle above that into the iliolumbar ligament. Okay, the posterior sacroiliac ligaments, they're going to sit a little bit deep to the other sacroiliac ligaments. We're going to hit these again, 3 locations. Let's look here. We'll locate the PSIS. Needle locations, and there'll be 3. We'll be at the PSIS. It's going to be 1 finger breadth caudal from the PSIS, and then 1 finger breadth cranial and medial. So here is our PSIS. 1 finger breadth inferior, 1 finger breadth superior, and medial. So 3 along the line right there, with PSIS being here. Superior most being a little bit more medial into that area. So posterior sacroiliac. PSIS. Okay, should hit PSIS as our backdrop. We'll drop 1 finger breadth inferior caudally. It should reach backdrop there. And then 1 finger breadth cranially and medially. For the posterior sacroiliac ligaments. Right there. For the sacrospinous ligaments, this will be the same way that we will needle the Coccygeus. We'll find our test location at the sacrococcygeal junction. We're going to move 1 finger breadth laterally, and we will add up to 1.5 centimeters to that. Total depth no greater than 2 centimeters. So again, talk to your patient about what you're doing. The sacrospinous ligament. The sacral interspinous ligaments are going to just be a half finger breadth off of midline of the sacrum. We can needle anywhere along the sacrum. For those, sacral supraspinous ligament is the white ligament in the middle, in which case we would do those purely in midline. So we'll come back, sacral supraspinous ligament there. We'll come back and now look at number 26 and number 27. So here we are in midline, cranial, caudal, on the sacrum, the cranial most piece of the sacrum. But there, it's just going to be about a half a finger breadth lateral from midline or the sacral spinous processes. And for the supraspinous process, it's going to absolutely be midline. for that ligament, for what higher up is the interspinous ligament. All right. Now onto the sciatic bursa of gluteus maximus. This is a again with people that with pain and tenderness on their ischial tuberosity or their sit bone. We're going to palpate that posterior ischial tuberosity. We're going to drop one finger breadth distally and needle directly onto the ischial tuberosity for treatment effect. You definitely caution for the location of sciatic nerve, just lateral to the ischial tuberosity. There's inferior gluteal veins and artery, the posterior femoral Pectineus nerve, which we will needle in lecture 12. So as long as we stay on that medial side of that, then we're going to needle into what we're looking for there. So we'll palpate, locate our ischial tuberosity, one finger breadth medial, and then we'll needle onto that, to the ischium as a backdrop right there. For the tendons of the semi-spinalis, semitendinosus, semimembranosus, and the biceps femoris. Again, here is the bursa of gluteus maximus. We just needled that. We can drop a little further inferior, and we're going to fairly superficially, we're going to drop another finger breadth, and we're going to needle from medial to lateral, not going too deep to avoid the sciatic nerve, which is going to sit right here. We definitely don't want to needle, obviously, into that. Again, caution for the location of the sciatic nerve. Let me go back. So we'll palpate the ischial tuberosity. They're in the prone position. We can resist knee flexion to identify the cranial-most aspect of the origin of the hamstrings. Needle placement is then going to be one finger breadth distal from the hamstring attachment, caudal or inferior to the ischial tuberosity. Will be PA with a slight angulation, 35, 40 degrees laterally. So that'll let us miss that sciatic nerve with that angulation. So palpate ischial tuberosity. We're going to resist knee flexion to identify the hamstrings at their attachment there on the ischium. We'll drop and we'll needle slightly medial to lateral through that tendinous attachment of the hamstrings. Okay, now we'll look at the trochanteric bursa, gluteus maximus, and then minimus, or medius. For troch bursa, gluteus maximus, it's also the superficial trochanteric bursa. It's lateral on the trochanter of the femur. This is what our patients traditionally will get injected. Will be sidelined for this. Needle length is 3 centimeters. It can be greater with a person with more adipose tissue out there. Backdrop is going to be on the greater trochanter. So we'll palpate for that lateralmost aspect. We're going to needle, the angulation is going to be lateral to medial onto the greater trochanter with periosteal pecking. So we're going to palpate. Patient's definitely going to let you know that is the site. And just lateral to medial, in this case, sky side to mat side, down to the greater troch for effect. So for the bursa of gluteus medius, same basic idea. We're going to move 2 finger breadths more proximal, and obviously we'll have a deeper needle placement to reach that further on the greater troch. Here, the needle length will be 3 to 5, same basic position. sideline. We'll palpate the lateral most aspect of the greater troch, and it'll be 2 finger breadths cranial. Angulation will be lateral to medial onto the greater troch, or possibly even down to the iliofemoral ligament. So again, find that greater troch. Once you've identified that, move 2 finger breadths more proximally. And again, definitely going to require a longer needle to get down to depth onto the greater troch or the iliofemoral ligament. Okay. Now, for the iliopectineus, so we'd mentioned also there's a trochanteric bursa of Gluteus Minimus. Too small to differentiate between that and medius. Assume that as you're needling Gluteus Medius, the trochanteric bursa, you're also going to get Gluteus Minimus. I believe the one for medius is less significant than for maximus, but again, they're probably communicating themselves. So I would needle maximus, then medius to get the effect that we're looking for. Iliopectineal bursa. Here, we're going to palpate for the femoral artery below the inguinal ligament. And we're going to move 3 finger breadths lateral towards and in line with the superiormost aspect of the greater trochanter. From there, we're going to needle anterior to posterior with the anterior joint capsule and the pubofemoral ligament as a backdrop. As you can tell, that's going to place us just lateral to the femoral nerve. So palpate for the femoral artery. We're going to move laterally 3 finger breadths in line with the superiormost aspect of the greater trochanter to needle down to the iliopectineal bursa. And I'm going to want to pull up this for just a moment, and let's put some muscle. Let's look at why that's relevant. So as you can see, iliopectineal bursa sits just posterior to iliopsoas. So if we have a tight hip flexor, if we've got something going, obviously that bursa is going to take a brunt of the trauma. And so any of that anterior hip business we'll look next week or next lecture when we look at hip OA and things of that nature. That bursa, that anterior hip iliopectineal bursa, can be a key item to target, as well as the hip flexor itself. Okay. Then the iliofemoral ligament, we will find ASIS and the lateralmost apex of the greater trochanter. We'll find a midpoint bisecting line, and we'll needle. We're in the sideline position. We'll needle top side to mat side to land onto the iliofemoral ligament. Trochanter on the ASIS midpoint for the iliofemoral ligament. For the ischiofemoral ligament. So ischiofemoral ligament, obviously the sciatic foramen, we want to be cautious of our location. Sciatic nerve itself is going to travel in this area right here. So we're going to be 2 finger breadths from the greater trochanter. So this is very similar to what we do for piriformis. Of note, piriformis sits 1 finger breadth cranial from here or superior. We come 2 finger breadths in the frontal plane, medial, and then 1 finger breadth superior. Here we just keep it at 2 finger breadths inferior, or 2 finger breadths medial in the frontal plane. And we do this way to avoid, give us our greatest protection for the sciatic nerve. We definitely want to be able to make sure we hit the ischiofemoral ligament, but at no risk to the sciatic nerve. So 2 finger breadths from there. So locating superior aspect of greater troch, we're going to move 2 finger breadths medially in a frontal plane and drop medial down to backdrop for the ischiofemoral ligament. On any of these ligaments, we absolutely have to hit backdrop, other than Coccygeus and Coccygeus and it's a ligament. Drawing a blank. That one we do not need to hit backdrop, but the others we absolutely do. Sacral spinous ligament. So that's what we do for ischiofemoral. And then pubofemoral ligament on the posterior aspect. Here, patient's going to be, or anterior, patient's going to be in the supine position. Back. We'll palpate for the femoral artery below the inguinal ligament. As you know, pubofemoral ligament is also the same as for iliopectineal bursa. So we can take that same approach. We can actually palpate for the artery, femoral artery, move 3 finger breadths lateral in line with superior most aspect of the greater trochanter, then drop our needle down posterior to anterior, definitely landing into that pubofemoral ligament as a backdrop. So palpate for femoral artery. We've already identified the superior most aspect of the greater trochanter. We'll move 3 finger breadths lateral from the femoral artery. That gets us on the lateral aspect of the femoral nerve. And then we'll drop all the way down to the pubofemoral ligament as our backdrop. And if you are paying attention, that gets us to the end of this lecture. And in record time, it is 1 hour and 37 minutes this time. It's okay. We've run over on a few of the others. Don't know why there's a picture of the wrist here. We're not doing wrist next. We did wrist last. No homework this time. The homework will come at the end of lecture number 12, which is in 2 weeks from now. So I will have this recording uploaded onto the student portal probably in the next 24 to 48 hours so that you can go back and review. If there are any other questions, issues in the meantime, feel free to send me a message and we will cover them as we need. Otherwise, happy learning. If you have questions with any of the material we've covered so far, yell at me, let me know. Otherwise, we'll see you in 2 weeks.